Let's talk about, CT versus ultrasound / fluoro for these. I've seen people doing them both ways. What's your technique using imaging?
Ultrasound and fluoro always. Yeah. And I say always with the caveat being sometimes you can't have it that way for whatever reason. Different hospitals have, you have different resources and available to you at different hospitals. So, I don't want to fault anyone who likes to do it under CT or, likes to do it with exclusively ultrasound, but I have my druthers, cholecystostomy tubes with combination of ultrasound and fluoro and in a cath lab setting.
Yeah, it's good to know both ways. I definitely prefer ultrasound fluoro because I like sticking it under real time under ultrasound and watching my wire coil within it under real time. Because like I said, when it gets all rubbery and tough and it's all inflamed, it can push away and you can end up even shearing the side of the gallbladder wall because it's not like sticking an abscess where it goes in and it usually will go in smoothly. It's all thick walled. And so what can happen is you can actually really get outside. You can really mess up the gallbladder wall if you don't, stick it dead on. And that's why I like to seal it in real time. That being said, CT is helpful at times when maybe you don't have ideal ultrasound, access. Maybe like we said, the gallbladder's way up under the rib cage. You don't have great visualization with ultrasound. Maybe that, the floor room's being taken up by a stat STEMI or something like that. And you have to do under CT. One of the guys I know in my old group, he likes it under CT. He says, look, to me, it's just like sticking an abscess. And so that's why he does it under CT. He feels like it's faster that way.
I mean, if that radiologist or interventionalist, if it's faster and safer for them, then I wouldn't argue that. But for me, it's definitely faster, definitely safer with ultrasound and fluoro for a couple of different reasons. First, it's the dynamic area. Like if you just think about how much the liver will move with respirations, especially if you have like some of those ICU patients who are just like doing like big, deep belly breathing. Yeah. I mean, like it's almost like your gallbladder can come in and out of focus and like you're just waiting for it to like pop back into your window before you stick it. And it is like an abscess, but I think there are some differences. And one of the things that you mentioned was that a lot of times the gallbladder wall can be more friable and, as opposed to like a well-formed abscess wall, which they're not all like that, but it's almost like a half-baked abscess in that if you're not careful, if you don't have pretty good wire discipline and also like dilating, I think it is easy to push through, or if you're not like pinning your wire very well, like with the dilators, or even when you're going on like with a stiff metallic or inner stiffener that's metallic, I think you can push through the gallbladder wall. And I think we've actually talked about that before where like I've done gallbladder cases where, I'm dilating up and then I go to put the tube in or like I'm adding a little bit more wire and it's just not tracking along the gallbladder lumen like I thought it was. Yeah. And I've been out and like I've pushed through and through, or at some point like somehow lost access. And I think in the cases that I can remember, it was because like I was just not like very disciplined with the wire, and I think I continued to push through it with the dilator.